In Chapter 20, we're going to talk about shock and the different types of shock. You guys may have heard of shock before, in a TV show or a movie, and it's often misused. Like the word shock is misused outside of pathophysiology and outside of medicine. But in terms of shock, pathophysiologically, it's an imbalance between oxygen supply and oxygen requirements at the cellular level, and this can relate to the heart or blood vessels, and it's basically just going to be inadequate oxygen delivery to your body's tissues. One of the common factors among all the different types of shock is hypoperfusion, so not enough blood perfusion, and also impaired cellular oxygen utilization. So cells might not be able to utilize any available oxygen if it is available. Inadequate cell oxygenation may result from decreased cardiac output, maldistribution of blood flow, or reduced blood oxygen content. And we'll talk about the subcategories of shock that relate to these particular causes. Now, the subcauses of shock can be cardiogenic, obstructive, hypovolemic, or distributive. Cardiogenic shock refers to shock that's due to inadequate cardiac output. So with cardiogenic shock, we'll have a sufficient vascular volume, like there's enough blood in the body, but the problem is that our cardiac output is too low to support proper metabolism of most of your body's tissues. So heart failure could cause cardiogenic shock. Now, obstructive shock is where you have some sort of circulatory blockage, like a pulmonary or embolus or cardiac tamponade. Remember, cardiac tamponade is external pressure on the heart due to an effusion that can compress the heart and prevent proper filling. But this obstruction also limits proper blood flow, and that can lead to shock. Hypovolemic shock just refers to low blood volume. This can be caused by loss of blood volume from hemorrhage or loss of extracellular fluid, like from burn or excessive dehydration. But either of these can lead to hypovolemic shock, which is attributable to low blood pressure from low blood volume. Now, distributive shock is going to be where you have maldistributed blood flow. So you might see greatly expanded vascular space or massive vasodilation that basically inappropriately shunts blood to different parts of your body and limits blood flow to other tissues that may need more oxygen. So with impaired tissue oxygenation, this lack of oxygen causes several different outcomes. For one, in the tissue, it leads to the production of lactate. Remember, lactate's the conjugate base of lactic acid, and so this is one of the signs of shock at the tissue level. Now, can also lead to a failure of ion pumps, and so we learned about this going back to reversible forms of cell injury, where if we can't make a sufficient amount of ATP due to low O2 levels, then sodium can't be effectively pumped out of the cell, which causes water accumulation due to osmosis and hydropic swelling. So you might see some swelling of tissues that can't effectively maintain their own ion pumps. The formation of oxygen-free radicals also occurs under anaerobic conditions, and these oxygen-free radicals have the capability of irreversibly damaging some of your body's molecules like proteins that are necessary for cell survival, and the induction of inflammatory cytokines, which can also lead to an immune response that can actually injure already damaged tissue. Now, this can result in, impaired tissue oxygenation can result from hypoxia, and hypoxia can come from, anaerobic metabolism, free radical production, or macrophage induction. And one thing that's important to note is that hypoxic tissues, because they can undergo anaerobic metabolism, produce an excessive amount of free radicals, and also induce the activity of macrophages. What we find is that due to these three factors, hypoxic tissues are prone to what we call reperfusion injury. Reperfusion injury is where you have ischemic cells that may produce oxygen-free radicals when oxygen supplies are restored. So, other free radicals can lead to the production of reactive oxygen species once oxygen is restored to this hypoxic tissue or even ischemic tissue. And that reperfusion, or basically reintroduction of blood flow to the already injured tissue itself, could damage the tissue further by leading to the production of free radicals. So if we suspect a tissue is ischemic or hypoxic, one therapy may be aimed at slowly reintroducing blood flow to avoid this reperfusion injury. Now, some of the clinical manifestations of shock all relate to basically the subcategories of shock, and also what you'd expect to see at the tissue level with inadequate metabolic needs being met. So we'll first start with heart rate. We should expect that if our body's tissues aren't being adequately perfused, or there's not enough oxygen being delivered to those tissues, this can lead to a compensatory increase in heart rate. That way you can try to increase cardiac output to perfuse enough of your body's tissues. And with this, you'll see a compensatory increase in respiratory rate. However, coinciding with this increase in heart rate and respiratory rate, you'll see things like diminished levels of consciousness due to a decrease in the perfusion of the brain tissue. Some other things that could occur, at least neurologically, could be things like thirst, restlessness, dilated pupils, as well as the release of antidiuretic hormone, whose purpose is to try to increase your blood pressure. So with that, you'll see hypotension or low blood pressure, as well as decreased pulse pressure. Release of aldosterone, which would also act to increase blood pressure, and cortisol, which is a stress hormone. We talked about how cortisol acts to increase blood sugar levels, and that would make sense in terms of supplying your body's tissues with enough energy to meet their metabolic needs. We can find too is also constriction of some of the splanchnic vessels, so vessels that you'd find in the abdominal viscera, and that can lead to things like nausea and abdominal pain. Otherwise, at the skin level, what you'll see is cool, clammy, bluish or gray color skin. This is due to low perfusion of the skin, as well as diminished capillary refill. Like if you push on the skin, you'll see that that sort of pallor that can result from pushing on that little skin area. Normally, that color will restore fairly rapidly, but under conditions of shock, you'll see diminished capillary refill due to low perfusion pressure. And also due to low perfusion pressure, you're going to see decreased urine output because the kidneys aren't receiving enough blood flow to make urine, and therefore an increase in the specific gravity of any already existing urine. Now, the first type of shock we're going to talk about is cardiogenic shock. Now, cardiogenic shock can usually result from severe ventricular dysfunction that's associated with myocardial infarct or sudden cardiac death of a particular area of the heart. And some diagnostic features of cardiogenic shock will be, for one, decreased cardiac output because the ventricles are failing to adequately pump blood out of the heart, elevated left ventricular and end diastolic pressure, preload. We can also see S3 heart sound, so a third heart sound that is typically not heard in older individuals over the age of 40 or untrained athletes. People who aren't athletes shouldn't really have an S3 heart sound unless they're undergoing heart failure. And what this S3 heart sound is believed to be is an additional heart sound, after S2, so after lub-dub. Then you can hear an additional sort of whooshing sound, which is believed to be a sloshing of blood within the ventricles, and this may be due to a diminished ejection fraction. So if there's a large end systolic volume and blood starts filling the ventricles again, and there's a lot of blood that this remains in the ventricles, that could create a sloshing sound, so this S3. What you should expect to see too from diminished cardiac output is pulmonary edema, or congestion of blood flow in the pulmonary circuit can increase pulmonary blood pressure, where fluid starts to get pushed into the interstitial spaces of your lungs, causing edema or fluid accumulation in the pulmonary or airways of your lungs, as well as a narrow pulse pressure, where we don't see large differences in systolic and diastolic pressures due to a decrease in the contractility of heart muscle itself. So some of the clinical features then you should expect to see would be low cardiac output. And so this low cardiac output will lead to reduced oxygen delivery to tissues, which means we'll have a lower blood oxygen levels. Now, the therapies of cardiogenic shock are aimed at improving cardiac output and as well as myocardial oxygen delivery, as well as decreasing the workload on the heart. And this is achieved through different things like inotropic agents. So you can have Positive inotropic agents, which can act to increase heart muscle contractility, that could be used to increase cardiac output. Otherwise, you might consider using a negative inotropic agent to decrease the contractility of heart muscle to decrease the workload on that heart muscle. Also reducing preload. Preload would refer to the amount of stretch you find in the ventricles. And so if you can reduce that preload, then it actually will put less stress on the heart muscle to contract, as well as reducing afterload. And afterload refers to diastolic pressure. So if you can lower someone's diastolic pressure, then there's less pressure that the ventricles need to overcome in order to force blood out of the heart. So it actually would take some stress off of the heart muscle itself. So one of the therapies you can use to decrease diastolic pressure, at least near the heart, or reduce afterload, is this intra-aortic ballooning counterpulsation. And this is an interesting phenomenon where you can actually place a balloon in the aorta, and what it'll do is actually inflate during ventricular diastole and deflate during ventricular systole. And it's the deflation of this balloon during ventricular systole that ultimately helps to reduce afterload and reduce diastolic pressure. It almost kind of sucks blood out of the heart instead of having the heart necessarily have to force blood out. And so it reduces some of the workload on the heart muscle and is an effective way to diminish stress on that tissue. And that you can see this with like ventricular assist devices or also with heart transplantation. Now, obstructive shock results from some sort of mechanical obstruction that prevents effective cardiac filling and stroke volume. So we talked about how a pulmonary embolism can lead to obstructive shock. If you have an embolus that starts in a peripheral vein, it travels to the right side of your heart, where the right side of the heart pumps it to the lungs. If that blocks a large vessel in the lungs, that can cause the pulmonary embolism, which diminishes blood flow beyond the lungs. Something else that can cause obstructive shock would be cardiac tamponade, where that external pressure on the outside of the heart can prevent proper heart chamber filling and also reduce proper blood flow, as well as tension pneumothorax, where changes in pressure within the thoracic cavity can also affect proper blood flow in the heart. Now, obstructive shock can manifest as right-sided heart failure, where we see a backup of blood flow in the systemic circuit. And in terms of treatment of obstructive shock, you want to see rapid management of underlying obstruction. So if it's an embolus, trying to clear out that embolism wherever it's located. And that way we can actually prevent any kind of cardiovascular collapse that can result from that obstruction. Now, hypovolemic shock we talked about as being the result of inadequate blood volume. And this blood volume reduction can come from things like massive hemorrhage, burns, which can result in a lot of loss of tissue fluid, which can also dehydrate your blood and reduce blood volume. Just general dehydration in the body can lead to hypovolemia or low blood volume, or leakage of fluid into interstitial spaces. You can have a condition where if someone's blood vessels are particularly leaky, some of the blood plasma could leave blood too quickly, and so you effectively reduce blood volume by having plasma leak into your own interstitial or tissue spaces. Now, external hemorrhage is the most common cause of hypovolemic shock, and so what this leads to then is that by having low blood volume, you'll see low cardiac output and low intracardiac pressures. Now, this leads to excessive sympathetic nervous system activation. So you see elevated heart rate, vasoconstriction, and increased contractility, which are all aimed at attempting to increase cardiac output and increase blood pressure. Now, distributive shock is characterized where you have excessive vasodilation and peripheral pooling of blood. So distributive shock is where you have maldistribution of blood flow, where you might have blood that pools in a particular organ due to massive vasodilation. So like blood pooling in the skin, rather than being allowed to effectively flow to internal organs. So this is where cardiac output's inadequate due to reduced preload. And so some of the different subtypes of distributive shock could be things like anaphylactic shock, neurogenic, or septic shock. So we know that anaphylactic shock comes about from exposure to some sort of allergen, and that allergen leads to vasodilation that causes anaphylaxis or shock that reduces proper blood flow. Neurogenic shock is actually where you have brain injury or trauma to the brainstem, such that the vasomotor centers of your brainstem don't work properly. You lose sympathetic tone, so that causes massive vasodilation. Blood pressure drops out, and therefore blood flow also slows down. Septic shock comes about from infection, where you might have bacteremia and sepsis, where those bacteria lead to the release of vasoactive chemicals by your immune system, which cause massive vasodilation throughout your body, and that can put you in a septic shock where you see pooling of blood and inadequate blood flow as a result of that infection. Now, anaphylaxis we just talked about, and as a result of excessive mast cell degranulation. It's mediated by IgA antibodies in response to some sort of hypersensitivity to a particular antigen. Now, these mast cells release these vasodilatory mediators, which cause severe hypotension. Things like histamine can lead to vasodilation, and therefore, if you have a lot of histamine released, that can lead to hypotension or low blood pressure. Now, it's important to note that low blood pressure reduces blood flow because blood only flows from high to low pressure. So if you get massive vasodilation and hypotension, then blood might not have a large pressure gradient to continually flow. Some causes of anaphylactic shock could be things like antibiotic allergies, like beta-lactam allergies, or allergies to different nuts like peanuts or tree nuts. Insect stings like bee stings or even snake bites can lead to anaphylactic shock. Now, some of the clinical symptoms of anaphylactic shock will include things like urticaria, bronchoconstriction, stridor, angioedema, wheezing, itching. And the maintenance of anaphylactic shock will be maintaining proper airway patency through the use of epinephrine and bronchodilators, as well as antihistamines and vasopressors to increase blood pressure, and administration of IV fluid to increase blood volume to also aim at increasing blood pressure. This differs from neurogenic shock. So neurogenic shock is still one of the distributive form of shocks, but this results from loss of sympathetic tone due to medullary depression, so damage to the medulla of your brainstem. This could come from brain injury or drug overdose, or even lesions of sympathetic nerve fibers from spinal cord injury. Now, the treatment of neurogenic shock will be aimed at administering vasopressors and fluids and elevating the legs. That way, blood pressure can be elevated in internal organs, which can keep you alive. You want to have slow position changes. That way you don't have blood moving from one part of your body to another too quickly due to changes in gravity, as well as the use of pressure stockings in legs to increase the return of venous blood back to the heart. Septic shock is the third form of distributive form of shock, and it results from severe systemic inflammatory response to some sort of infection. So the infection can lead to the release of these inflammatory molecules, including vasodilators. And this can be a response from gram-negative or gram-positive bacteria, even fungal infections. And this can lead to massive vasodilation, which can actually induce shock, similar to the other forms of distributive shock, but this results from infection. There's another form of shock we call gram-negative shock, and this results from endotoxins in bacterial cell walls that can also stimulate massive immune cell activation. So we talked about how if someone has a C. diff infection that's cleared off too rapidly, sometimes the endotoxins of that C. diff can lead to shock if you actually kill off bacteria too quickly. Now, septic shock is characterized by the release of these immune mediators, like we talked about, that result in widespread inflammation. But remember, one of the components of inflammation was vasodilation. So we see activation of the clotting cascade, complement, and the kinin system, but this widespread inflammation leads to profound peripheral vasodilation, which leads to hypotension and therefore maldistribution of blood flow. And that can lead to cell hypoxia and possibly even edema formation in peripheral tissues. Now, initially we can see that you have high cardiac output due to sympathetic activation, but even though cardiac output is high, cell hypoxia can be present due to inadequate blood flow, or at least maldistribution of that blood flow. So you see reduced cell oxygenation utilization, and this can lead to a deterioration of this hypodynamic phase, where we see decreased cardiac output and organ ischemia because of diminished blood oxygen levels, which decrease your myocardium's ability to pump blood. Now, septic shock therapy is aimed at improving distribution of blood flow and managing infection with antibiotics, but administration of fluids and drugs to improve cardiac and vascular performance are aimed at improving blood flow, cardiac output, and blood pressure.